I'm Jonathan Wang, the founder of the Youth Advocates for Global Health Association. We are a youth-led nonprofit organization, and our vision is to establish a united global youth community committed to advancing global health equity and fostering human health and well-being. Through initiatives centered on research, community projects, public advocacy, and international engagement, we strive to shape a healthier, more equitable future for all. Some of our past projects include a health outreach programs in Africa, hosting international medical conferences, and organizing impactful webinars on critical health topics.
Yes, good afternoon, everyone. My name is Matthew Yu. I'm the Vice President of the Youth Advocates for Global Health Association. Today, we're excited to explore the topic of common cardiac complaints in athletes. And we are so honored to be joined by Dr. Dehghani, whose expertise in cardiology and sports medicine offers invaluable insight into this very important subject. Dr. Dehghani is a clinical co-director of the Prairie Vascular Research Inc. and an associate professor at the University of Saskatchewan. He is an interventional cardiologist at the Regina Qu'Appelle Health Region and director of the Adults with Structural Heart Disease Clinic. Dr. Dehghani has extensive experience working with athletes to diagnose and manage cardiac issues that can impact performance and safety, and we look forward to learning from his knowledge and clinical experience. And obviously, Dr. Dehghani will tell us a lot more about himself as well.
Yeah, following the presentation, we will have a Q&A period where all webinar participants may submit their questions using the chat function. But without further ado, let's give a warm welcome to Dr. Dehghani. Thank you so much for joining us today.
So we're so proud of you guys. Anything we can do to support what you're doing is fantastic. And this is not just out of meritocracy. This is, I truly believe youth can move the world. And it starts with initiatives like this. So keep it up. So guys, over the next 30 minutes, we're going to keep this short. I made this sort of youth friendly. My kids are on sports. A lot of the participants here coming on have also the same kind of interests. We're going to sort of talk about the things that you see on this screen: wearables, fainting, chest pain, what happens when you're running and you have a cold, or endurance runners, and this idea of automatic external defibrillators. And I'll do it the way we do everything in medicine, which is we do cases. So I'll start with, what happens when you get a funny heartbeats. A lot of the times, we see patients like you guys in your age come to us and say, my heartbeat feels funny after I exercise. And it's like anything in medicine, it's all about the story. Is it a malignant sounding story, or is it a benign sounding story? So instead of telling you, I'm going to just actually ask you to hear it. So I hope you can hear that loved up. All of our hearts have this loved up sensation, and it's normal when you exercise to get an exaggerated sensation of this loved up, which is the closing of the ventricular valves, atrioventricular valves. So this usually corresponds to the upper chamber of the heart, which you see on top, contracting, and these are the valves that make the sounds when we hear that. So that's what you're feeling when you see that. If I were to show you on MRI, which is what we do, again, this MRI is a beautiful example. If you can see ventricular contraction of the heart, and the upper chambers here are the atria. So this is what happens when the chambers of the heart contract. And that's a normal sounding heart sounds, and it's okay for you to hear that. And it turns out that the way the sequence of depolarization of the electrical highways of the heart work is the way we can stimulate the different myocardial muscles that will contract, and then will eventually close the valve. So it is normal for us to hear or have a sensation of extra heart sounds. Instead of, I'm sorry you can't hear it, but the sound you'd be hearing, and I literally do this, and I'm glad actually, it's something in medicine, Matthew, you have to learn, is you have to roll with it, whatever happens. So this is an example of rolling with it. I get my patients to actually sound out what they're talking about. I say, is it a lub dub, or is it literally like a sawtooth that goes consistently? That usually means there's something happening. So here, as you can see, the contractions of the heart are different. Instead of an upper chamber and a lower chamber going, everything is going at the same time. This usually means that there's a circuit problem and it's going way too fast. So even if me, and I think I know what I'm talking about, even if I were to sense that, I wouldn't believe it until I see it. So this is why something like a wearable or those tracings of the heart such as an Apple phone or some of these, even the Galaxy. I was helping an older lady in my office last week. The smart Galaxy series also have them. The ability to see these strips is very important to us because we can see what those electrical highways look like. So next time you guys get sensations or funny things like that, I urge you to take advantage of the world we live in and have a wearable that actually records these things. One of the things I want to talk to you about, because you guys are young and you're going to be embarking in whatever field, whether it's medicine, science, or academics, is the technology has changed so much. This is a classic study that was published about 4 or 5 years ago. It's called the Apple Heart Study, that came after the Apple Watch was came up. And I'll just tell you some of the features that makes this so unique in our world. So I lead a research center here in Saskatchewan with regards to cardiac healthcare. And I can tell you, for example, in our center or in a multi-million-dollar trial, for us to get to, say, 2,000 patients within 2 years is fantastic because these are difficult trials. Look at the number of patients they got to within 8 months. And this is because of a novel virtual design. People on Apple Watch were asked for consent. They gave permission to be able to send their recordings. So this is going to significantly impact how we're going to look at science. And in this particular study, the finding isn't so important as the design of these studies. It wanted to see whether it has the ability to be able to look at abnormal heart rhythms. So, there's, instead of the normal electrical highway, is it going through a different circuit? And again, we can tell that by looking at the actual strips of the heart. And it ended up being a very successful and important study. So what should you do if your heart beats funny? If it's a few skipped heartbeats, remember a lot of us in sports, especially if you're dehydrated, are going to feel that. That's probably okay. If it's persistent and does not go away, the other thing I ask people is if you put your hand on your chest and if you actually feel a fluttering of your chest wall, that's not normal. And then take advantage of today's world. If you have a wearable that has the ability to get the tracing, a lot of, all these have the ability, and then you literally say, press send, you put your fingers, say, on the Apple Watch, it records it for 30 seconds. It puts it in your iPhone. Next time you see your doctor, your cardiologist, you can actually show them the PDF. That is extremely powerful because it can tell us where the heart comes from. It's a surrogate for the technology. Okay, so that's heartbeat. Here's another one. My chest hurts. Guys, just give me 1 second. These guys are not letting me alone. It's okay. You get to see what life is like with for the cardiologist on call. So someone's having chest pain. It's funny. I'm talking about chest pain. There's a lady having chest pain.
Called it.
No problem. Please get consent. We will come in to do. This is better than the talk. You're seeing me in live action. We'll come in to do the angiogram.
Ask her to join the Zoom.
No.
Here's some advice.
No, I have to go in and open this person's heart. So arteries, because it looks like it's being plugged. So
and yeah, once again, we really thank Dr. Dehghani for joining us. Very busy with the schedule, always treating patients. So really thank you for taking the time. And
oh, it's fun. I'm telling you, I have a soft spot for youth because I have youth. I have 4 kids. We're and some of the folks here are dads, so we get it and we support you guys completely. So my chest hurts. Isn't it ironic? I'm literally dealing with acute chest pain. But it turns out that chest pain, especially in your guys' population, young athletes. I know, Matthew, you're a crazy skater. You're extremely fit and stuff. There's going to be times where you're going to have pain. It has to do with how much you've exerted yourself. We have all these intercostal muscles. There's some neuromuscular fibers underneath it. They can get inflamed. So it is not abnormal for people to get chest pain, but the kind of pain that I'm just getting called about as we speak because of the tracing is very different than, again, 95% of the types of chest pain you guys tend to have. And for us in our world, it has to do with how good the story is. Does the story sound like it's coming from blocked arteries? Does it sound like a tender to touch, which usually makes it more superficial? There's certain features that you go to med school for and study and helps you become a good detective of really understanding where the pain comes from. There's radiation patterns that we know of what's concerning, what's not. So after all of this, and there's physical exam findings that we have to study and reproduce, After all of this, we can sort it out. Now, the kind of person that I just got a call about is probably going to be this. So this is my catheter inside someone's heart, and this person's having an acute heart attack. Can someone tell me what they see? I realize you haven't seen a lot of these. This is my catheter, and the black is the dye. Would you guys, anyone see any abnormalities in this? So I ask you to look for persistence of dye. That usually implies there's a blockage somewhere. So again, I appreciate you haven't seen a lot of these. I see a million of these a day. I'm going to put my cursor. Do you see my cursor, Matthew, or no?
Yes, I see your cursor.
Okay, so the cursor, look at where the cursor ends. So look at right here. That vessel is blocked because there's a persistence of dye here. So this person has a ruptured plaque with a clot here. And this is why they're having ongoing chest pain. And what I have to do is I go to the next slide. This is what they look like before I start. And then I put my catheter, I put a wire through the artery. I suck the clot out. Do you guys see these serpiginous small clots that have blocked it? And usually we literally sometimes have a vacuum or other tools that are disposal, and we can get these things out. So that's an example of a heart attack. And, there's features, I think Chase is here. Chase is a med student who works with me. We have had a few of these cases. There's typical features that are typical for ischemia, and there are some that are not. So we look at the history and we go from there. So that is chest pain. Sometimes it requires my help. Sometimes it does not require my help. Now, I feel faint. This is a very common. Again, you won't hear the audio well, so I'll just supplement it with what I say. Do you ever feel faint before, after, or what happens with you?
Yes, I definitely do. There's been many times during training where it's just like I suddenly feel really faint and I can't get up for some reason, and it's happened a few times, and it's a bit scary, honestly.
Yeah. So let me show you. This is I was just playing tennis, guys, with my friend Viv. Let me show you a real clip. You won't hear this. This is after a long point of tennis. This is, I think, like 12 years ago. So professional tennis. You don't need to hear. You don't care about the audio. In fact, I'm gonna mute it. So look, she's walking back and she's standing here and she just goes. And I want you to see as she's fainting, so people rush to her. She's moving. You see that she's moving. She's moving her arm. Usually at this point, they're not purposeful. They're not really making sense, but enough that this coach comes and gives her water. You're going to see it in slow motion. You guys tell me, is this a normal faint or abnormal faint, if there is such a thing as a normal faint? And she's being carried through. She's white. So this is an example of probably a normal faint. She's dehydrated. And this is a blood pressure mediated issue. This is another one. This is a NASA. This is a famous, after one of their trips. So they come home, they get deconditioned because their issues with gravity has totally messed them up. So this is after a few days rest. She's coming to give a statement. Again, you won't be able to hear it, but I want you to look at her. She's talking, and then she stops making sense, and she goes down. And
Yeah, preparation we had, training the team.
And it actually happens twice, but just look at her eyes. She's not quite there. So this is usually a blood pressure effect for someone who has been either working hard or has been sick. The blood pressure isn't there. So everyone's concerned. They start talking to her and they make her feel better. She's feeling better now. Look, little less white, but look, it's going to happen again. Watch.
So I don't get people worried standing up here too long.
And as she's talking again, there's the sweatiness that Matthew was talking about. She gets extra sweaty. She's pale.
Stand here, standing enough.
And look, it happens one more time. So this is what happened when the blood pressure is so low that patient is fainting. This, believe it or not, is actually a benign form of fainting. This is called vasovagal syncope. So I'm going to let this video run. There's this, you guys are going to learn all of this in sciences if you haven't already, but our brain is connected to the heart through this thing called the vagus nerve. And when a stimulus is sent to this vagus nerve where the control center of the brain is, a stimulus could be, not having, being dehydrated all day or being in a hot day. I know Ivan was working today in a hot day. Sometimes if you're not hydrated enough, this starts get going, and then you start sending these what we call efferent response system, and the nerves go right to what innervates our heart. This is the part that's responsible for the blood pressure in our heart. So it starts stimulating the part of the heart that is responsible for pumping blood to the lungs and back to the aorta. And what can happen is this is normal flow, but in the setting of a stimulated vagal response, the pressure, look at the stimulus coming down, the pressure goes so low that you literally just are not pumping enough. And everything goes super slow. You see how everything is so slow. The reason you and I feel faint is all to do with our brain. Our brain is not getting enough blood. Believe it or not, this sounds terrible. It sounds like you're going to die, but this is very benign. This was an evolutionary thing. When you and I were running away from dinosaurs thousands of years ago, we needed a mechanism to slow us down. Otherwise, our heart would go so fast. So this is Mother Nature's evolutionary response to slow us down, except in some of the athletes or in some setting, this gets overstimulated. So you start being too stimulated with the what we call the vagal response, and you have this low blood pressure, which causes fainting. Now, contrast that to that. Who watches football here? I know Chase is a football player. This is a famous thing that happened just a few years ago. Just look at this, the way this feint is. I'm going to let this play. And he just faints. But look, absolutely no response. So first of all, he gets hit in the chest, comes down, gets up. Look at number 3, gets up, and then he just goes down. So there's nothing happening. This is an example of a very dangerous kind of a feint where there's absolutely no response. This is not a blood pressure thing. This is everything. And it turns out this is in this particular case, this was called commotion cordis, this NFL player had, and this has been well described. Here's a karate tournament where there's 2 young people having a well-regulated karate match. This was later published. And everything's kosher. This person has a jab directly to the chest, and this person just drops, and everyone watches, and unfortunately he dies. It's because what happens is you strike the heart at this one part of depolarization of the electrocardiogram where the heart is depolarizing, and you get it to go into the short circuit where the heart will stop unless you can bring it back to life. And we'll talk about that. Believe it or not, they did this with an animal model where they would throw baseballs to their chest, these poor swine. And depending on where you hit them on their electrocardiogram, you could induce the heart to stop. So this is why, sometimes you get into fights and stuff or whatever, but the odd time, if you get hit in the chest at the exact millisecond of where it's supposed to be, you can potentially induce this dangerous rhythm and people can die. What saves people in this patient population is a quick zap to their heart. Okay? So that is fainting, which we're going to talk about. So what should you do if you faint? Well, if you're dehydrated, had warning signs, usually people feel faint. They say, oh, my vision is going, I don't hear things. Matthew usually knows, for example, when he's overdoing it. Those tend to be okay. Sit your butt down, get some fluid in your system, usually raise your legs. If there's absolutely no warning signs and some things happen what we call acute onset, acute offset, that's a potential problem. We're going to talk about one last thing before we put it all together. But so here's a chief complaint. I'm an endurance athlete and I just had a cold. Should I go for a run? Out of curiosity, Matthew, I guess you'd be considered an endurance athlete, right? I don't know what you'd consider, but what is your recommendation? What do your coaches tell you? If you have a cold, do they say come, don't come? What do they tell you?
Oh yeah, everyone who has a cold just comes and just trains, and no one stays home at all, even if they're suffering. Yeah.
Let me explain to you the science here. This concept of dropping dead unfortunately happens in very healthy athletes. You either heard about it, your parents have heard about, their so-and-so best fit friend all of a sudden dropping dead, or I can't believe that coach was so fit. How did this happen? Or this guy wasn't overweight. What had happened? Well, there's a whole science of this called sudden cardiac death, and particularly in athletes. And, sometimes we can find causes, and my job is to, when they come in with, if their heart has stopped and it's resumed again, my job is to see what they have. Sometimes we don't really understand it. So it's not explained in about 30 to 40% of the patients. And it has to do with, particularly with our endurance athletes, with their hearts. The guys or the ladies who are running, say, more than 60, 70 kilometers per week, if this is your normal heart on the left, look how it becomes different on the right. Jonathan, what do you notice the right compared to left in terms of the chamber sizes?
Well, I definitely noticed the one on the right is larger. I would assume that's because of more training of the
Yeah,
cardiovascular
so
muscles.
we know if you are a marathon runner, especially have to go for a marathon, if I do an MRI on your heart, it's going to look like this. It's bigger and it's more dilated. Most of the time, if you detrain or if you relax, what happens to the heart? It shrinks back to normal, which is great. But it turns out, and also it turns out there's a difference between those of you who are lifters, who do weights or pressure overload versus those who are runners. So we have this concept called eccentric hypertrophy where the heart dilates versus a concentric hypertrophy where it becomes thicker. And both of these, if you stop training, usually turn back to normal. But there's something specific about the volume overload train endurance patients. Chase, are you on? Is Chase on here too? Yeah, Chase is here. So Chase and I are literally submitting an article. Chase, maybe you can tell us quickly what we're submitting an article on to this audience.
Yeah, so we did a systematic review looking at coronary artery calcium scores in endurance athletes. There's kind of been ongoing research now for about 20 years looking into this idea of whether or not long, excessive endurance exercise may actually increase coronary artery disease. So what we did is we systematically looked at the literature to see whether or not, one, is that true? And then two, whether or not that translates to worse outcomes, such as like heart attack, death. And basically, the findings of it were that there is potentially an increased association with more disease in the arteries, but interestingly enough, it doesn't translate to higher rates of mortality or heart attacks or anything like that. So there's definitely some complexity to the story, but it appears that while it does cause more disease, it's still protective from a outcome perspective.
Yeah, so thank you, Chase. This is a great presentation for you guys. You see me live in action in many ways. So, if I don't know if you guys, those of you on who are going to maybe wanting to do science. So Chase is a med student, third and fourth year. He's been working with me for 2, 3 years. We have about 10 or 12 publications together. How many do we have? Chase is a bit of an outlier. Usually people are not this productive, but he's been amazing. But it's been very interesting. I can tell you as a mentor and someone who's probably your dad's age, the best thing you can do with people who you admire is if you work with them and produce with them things that we can publish. As a research person, that to me is great, and it's actually very good for your own CV. So Chase has been very successful as a first author in about, I think, a total of 17 articles or something, but with me about 12 in the last 2, 3 years. So as he said, there's some really cool nuances. It turns out if you're a crazy endurance athlete, it may not necessarily be that good. But there's a really cool physiology that comes with people who are lifters, who are strength trainers versus endurance. We see slight differences in their blood pressure versus diastolic blood pressure, which is beyond the scope of this talk. But suffice it to say that there's a concept that as the heart keeps dilating and coming down, you start scarring the heart. You literally, well, you see these arrows. These scars are not reversible. So, I just told you, you go for a run, the heart, like a big run, the heart dilates, you stop, probably Matthew, after your crazy training, I don't know if you go on like little binges of training, it's probably dilated. Once you detrain, it comes down. That's okay. But if someone does this consistently, these scars are formed. And guess what? These scars are potential nidus or focus for these short circuits in the electrical pathway. This was a 29-year-old who had a cold a few weeks ago, died suddenly, and then they did an autopsy. He he'd had an MRI 3 weeks ago and then dies 3 weeks later. In retrospect, on the MRI, there's these what we call delayed enhancement, and these scars correspond. The poor guy had an autopsy, as his family allowed it, and he allowed it, to these areas of fibrogenicity that literally get in the way of the electrical pathway. And this was the reason why he passed away. So, here's an example of a heart that is not quite normal. So this is the left side of the heart is pumping nicely, but this part is abnormal the way it's pumping, likely related to scarring. So, with endurance athletes, there's a bit of a J curve. In other words, there's being able to do 10, 15 kilometers is fantastic for you to be in shape. Being more than that is probably really good for your overall fitness, but does it really give you a longevity, which is what you and I want? You and I want to be able to live for a long time, but live with good quality of life and not have issues. And those are the things we're always trying to sort out. With any sudden cardiac death, there's different triggers. So we talked about scar related. That's an example of these fibrosis. Sometimes there's a rupture of plaque. That's a heart attack. There's drugs. We had some high school students actually shadow me, come to the Emerge. And again, Chase was kind enough to take them. We had a young man who was doing crack cocaine, again, beautiful on the outside. He was a lifter, crack cocaine, but his heart function was really poor. Myocarditis is an example of getting a cold or viral illness that affects your heart. So if you have a cold, probably should stay away from strenuous physical activity. I don't want to go against your coaches, Matthew, but I think strenuous in a setting of a heart that's not quite right. It's not a matter of being a wimp or pushing yourself. I'm sure a lot of these guys by this time they're not wimps. It's just an issue to do potentially with heart. So my feeling is if you really do have a cold, you shouldn't be doing it.
Can be seen coming out of a timeout huddle, his head dropping. He stumbles, then alarmingly, he falls face first.
Here you see Keontae head drop, stumble, sudden collapse. This is what sudden cardiac arrest in an athlete looks like.
Collapses, just like Hamlin did in sports from football, cross, to baseball.
Mark Vivian Foe, he shows all the signs of sudden cardiac arrest, continue breathing after collapse. Eyes open and rolled back, the face of sudden cardiac arrest. For Damar, after his arrest, his arms go up with seizure-like activity. For Christian Erickson, sudden collapse, also unresponsive, eyes open, brief seizure activity in his leg. This is sudden cardiac arrest.
We've been there, but that's not a good look at all.
With Claire, dramatic episode, collapse with seizure-like activity in the arms, amazing emergency response. Call for help, someone go get the AED. Remember, in a collapsed athlete that is unresponsive to verbal stimuli and a shoulder tap, you must assume it's sudden cardiac arrest. Call for help, start chest compressions, get the AED. Anyone can save a life.
You guys are well-meaning people who want to save the world. This is part of one of the things we should be aware of is if you see someone drop and they're unresponsive. You remember the tennis player, she wasn't unresponsive. She was able to drink water, but they're unresponsive. You're going to have to assume that the heart has stopped. We just removed, I don't want to give too much personal information, but there was a 42-year-old basketball player playing basketball just last week, fell down, collapsed, CPR for 10 minutes. Finally, the EMS came, automatic external defibrillated the patient, but now the brain is not back, and we will likely have to pull the plug on a 42-year-old. So, and he had a heart that wasn't quite normal, and if there was a defibrillator around, that person could have been saved. So, these are things that you can be aware of that will make you just better, more responsible citizens. If you do see that, you ask obviously for 911. But in most centers now, there should be an AED. And, we have a public campaign to try to educate everyone to how to operate an AED. So in conclusion, what did we talk about today? We talked about some of the things, I tried to focus it on young athletes. I know you're going to record this for your audience of young people and give it to them on the webcast. But, wearables and technology is very common. It would be a shame if you don't use that to your advantage. I'm very proud when I see even a 75-year-old old grandma come to my office, say, "Hey, doc, this is my tracing I got on my Apple Watch, on my iPhone. Can I email it to you?" I love that that she's taking full advantage of what her heart looks like, and I can really help her. We talked about syncope or fainting. I told you about differences of what to look for. A person who collapses without any responsiveness, eyes rolled back, versus someone who does, and the need to get an external defibrillator. I showed you, I gave you a live demonstration of someone with acute chest pain, which I've called the team in for. So as soon as we hang up, I'm going to go because I have about a 15-minute lead time before they have to set everything up. We talked about running or endurance athletes and potentially what can go wrong with hearts that are bigger. And then finally, you guys can save lives. You don't have to be a cardiologist or at least understand where this comes from. So we have about 5-10 minutes for questions. And I try to keep the level engaging with some cool videos and not make it too sciencey. But please, you guys ask whatever you want to ask. I'm happy to help.
Thank you, Dr. Dehghani, for that very insightful and enjoyable presentation. My first question would be like how athletes can differentiate between normal exercise-related symptoms and those indicating a cardiac problem.
That's tough. I mean, we went through some of those scenarios. And for me, it's sort of like the example is, when you're sore after a workout versus tenderness, there's a difference for us. Being sore is a good thing, but having so much pain with palpation, that's not a good thing. So some of that comes with experience, but I think if it's literally getting in the way, all of us, even in people who train, if you look at training, it's never linear, it's dynamic. So they'll go like this and then they'll get better and then they'll get better. But if we find that patients are actually declining and can't do the same thing despite, some rest and time, then I think it's important to get checked out. Full loss of consciousness without any responsiveness, that's important to note that as well. And remember, there's some parents here. A lot of times you can lean on your parents, at least even if they're not cardiologists, they've had a life, they've been active themselves. So often I think moms and dads have a good sense of what's not normal and what's normal. I can tell you there is a point after which you say, "Come on, man, how come you didn't come see us earlier?" We had a 24-year-old who had gone to about 5 walk-in clinics because he just wouldn't get rid of the cough. I said, "Well, why didn't you come earlier?" He goes, "Oh, I've always had a cough." I said, "Yeah, I know, but what's different this time is he couldn't walk a block." This is a healthy 24-year-old without being short of breath. That's extremely abnormal, right? So things that are way out of keeping, outliers from your history, I think can help.
Okay, thank you for that response. Before we get to some questions in the chat, just reminding everyone you may type your questions in the chat. I did just want to ask, how common is sudden cardiac death? Because it seems very scary. So how common is it, and what guidelines should be put into place to help prevent sudden cardiac death in athletes?
Yeah, good question. I think if you look at elite athletes, it's in the order of 1 in 500 to 1 in 1,000. Remember, they don't have to die, right? It's an attempt to die. It's a lot of times it's aborted sudden cardiac death. And by definition, you can't really prevent sudden cardiac death. You have to have the capability to treat it. Obviously, remember, a lot of these people are extremely healthy specimen, right? They're not going to be complaining to you. And sometimes, as you would know, Matthew, when you overtrain, you literally shut off your body's signals. Your body has stopped asking for help because your brain doesn't listen, right? That's why you're probably super fit, because their body's like, "Come on, man, it hurts," but you've turned off all your signals. So as a general rule, a lot of our elite athletes, highly competitive athletes, you can't rely on their body signals. So, programs have insisted on an automatic external defibrillator. I think education programs where peers, because remember, who hangs out with you the most? Probably other high-end skaters, or for me and my friends when I go play tennis, other tennis players. So we have to educate each other about things that are treatable. But by definition, sudden cardiac death you can't prevent, because a lot of times these guys are healthy people, healthier than the average population.
So that leads me into my next question. Should routine cardiac screening be recommended for young athletes?
Good question. So, there was a study looking at routine echocardiography on everyone on a population basis, and it didn't pan out. Like the added, sometimes when we do unnecessary tests, it leads to unnecessary investigations. And the pros did not outwin the cons. In some of our, we have certain risk factors. For example, if you're super tall, as you know, Matthew, I've got basketball players as kids. If you're super tall and you have some features, sometimes we want to look at what their heart looks like. Because it turns out if you're above a certain height, 6'4", 6'5", the chance of you having a mildly abnormal heart is slightly higher. Um, some of the professional programs, so we work with the Rough Riders, they don't have a screening program, but as soon as something is funny, they need an okay from us, which usually includes an ultrasound and things. So at this time, there's no general screening. There are certain associations, professional associations, that when they look at certain things like the height's too big, they will start doing things like echocardiograms to make sure the heart is okay.
Amazing. Thank you for that response. Another question that I had was if can athletes with congenital heart defects safely participate in competitive sports, or would you say that they're more limited in their options when doing physical activity?
Great question. This feels like it's a planted question because I run the clinic for adults with congenital heart disease. We have very good guidelines on what they should do. I'll tell you a common one I just saw 3 weeks ago. This guy was just got a varsity scholarship for a U.S. football. And football is very, acute acceleration, acute deceleration kind of a sport. But his aorta is bigger than it should be. So, you and my aorta is about 3.5 centimeters at max. His was 4.9. Anything above 5.5 we like to operate on. The problem is with 4.9 aortas, especially if when they do their endurance, when they do their strength training, and that Valsalva maneuver they do, or the big hits that they do, that's not good for the aorta. It can dilate and potentially cause rupture. So there are, thankfully by now, very specific guidelines. Unfortunately, as was the case with this young man, his parents came kicking and screaming, saying, "Are you crazy? This guy just got a scholarship. You're not going to give him the green light. He's going to lose it. This is his dream." Unfortunately, these things happen. But I'm for the patient. I'm the patient's advocate. We just don't want them to drop dead. But luckily now it's not like, oh, Dr. Dehghani says no. Now it's more like, well, Dr. Dehghani, as per guidelines from American College of Cardiology and Canadian College of Cardiology, says do not do this. So that's been very helpful.
Great, thank you for that response. Let's address some of the questions in the chat. The first question I see is, do you often see asymptomatic patients inquiring about performance improvements?
That's Joe. Asymptomatic patient inquiring about. I think what Joe's getting at is people have no symptoms at all, saying, "Hey, can we do better?" Sometimes we see that, and what I do is I put them on the stress test. Look at their thing. This concept called chronotropic competence. We want to literally see how high their heart rate goes. We can do more granular testing, something called cardiopulmonary exercise stress testing, where we look at their metabolic oxygen uptake from what they breathe in, breathe out. And then we can see if they're hitting a ceiling earlier than later. But I would say that would be rare. In some of these very high-end programs, they have exercise physiologists who help with these patients. But I can tell you guys something. It is extremely uncommon for the heart to be the limiting factor in our athletes. The athletes who are just amazing specimen often have three things in common. They work like crazy. They have an incredible work ethic. They have parents who are extremely supportive. And there is a diet/environmental factor, right? They eat the right things, they're in the right environment, they sleep well. It's extremely unlikely that I would say, oh, because of this blocked artery, you're not doing well. You won't believe it, but people whose heart function is poor can still run marathons and be fitter than me because everything else is so good. Their body tone is good, their muscle is good, muscle tone is good. So we do see that sometimes, Joe, but not all the time.
Yeah, I totally agree with that. We did have another question from the chat that asked, in a cardiac emergency, how do I know when to start CPR versus when to only call EMS and start treating for shock recovery position?
Oh, that's a good question. Thank you, Radin. I see Radin has that question. You start CPR when there's no pulse. That's as easy as that. If there's no pulse, you start CPR and call 911. I wouldn't do one or the other. You would just do both. When you say treat for shock, I'm assuming you mean automatic external defibrillator shock. As soon as there's no pulse, you ask for someone. I tell them two things. Call 911 and ask for a defibrillator. Is there a defibrillator in the setting? In most, we've done a very extensive public program where I was just at a gym this morning. They gave the owner a hard time because his AED, the battery was out. But we've gone through an extensive program where we were educating the public. So I think as soon as there's no pulse and patient is not responsive, and many of you may say, well, I don't know how to get a pulse. I think for you, if there's no patient is not responsive, call 911 and get a defibrillator. It's actually very easy. They made it very idiot-proof, even for doctors who haven't done them for a while. There's usually 3 steps. You put it on, the machine says yes, zap it, and then you zap it. So that's what I would do.
Thank you for your insight about that. I think it's very important for us to understand how to deal with these sorts of situations. And by the way, Dr. Dehghani, I know you have a patient waiting for you. If at any time you have to go or anything, just let us know.
One thing you have to learn, guys. Well, Matthew, you'd be good at this. You're a high-end competitor. You have to just be cool. As even if the patient is dying, God forbid, and this person sounds actually kind of unstable. But I'm confident in that I have a good team and I will do the best I can. So I don't really get nervous. It comes with the training.
Yeah.
No, I have about 1 more minute, guys. Any other things? Any final questions?
Okay, I think the last thing we just wanted to ask is, for young people interested in cardiology or sports medicine, what are some important steps to take on?
As a profession, you mean?
Potentially.
Yeah. I think it starts with this stuff. Being intrigued. You got to find your passion, guys. It sounds cliche, but you really have to find your passion. It's the passion that will drive everything else. I wouldn't do it because of your parents. I know my kid is going into Spain wants really to do medicine. Our son, who's Matthew's age, and I brought him in for a few heart attacks. So you sure? You sure this is what you want to deal with? And I think he is, and he enjoys the family interaction. So first, I think you have to test the water, look at the different things, and just pretend, skip forward 20, 30 years. You're my age in your early 50s. You're halfway through that chapter of your life, and you're going to still have to be interested and be intrigued and be curious. And I think if you lose curiosity and intrigue and you become obsolete, then any job is terrible. But if anything that can keep you motivated, and for me it was this, because there's so many questions I like to ask. I love the research aspect. I love the working with my hands. That it really worked for me. So I would just say, just stay curious and go along with the ride.
Amazing. Thank you so much. Well, thank you again, once again, Dr. Dehghani, for that very informative and insightful presentation on cardiac complaints in athletes. Your expertise has given us a deeper understanding of the importance of cardiac health in athletic performance and safety.
We also want to thank everyone who joined us today and engaged with the topic. Your participation and curiosity play a crucial role in advancing global health awareness and supporting youth health advocacy.
To learn more about our organization and to register for future webinars, please visit ygha.org.
If you have any further questions or want to continue the conversation, don't hesitate to reach out to us through our social media channels or email. Together, we can continue to build a healthier, stronger global community.